Am I audible, sir?
Yes.
Okay. Shall I start?
Yeah. Yes.
Okay. Good morning, one and all. Today, my topic of discussion is cerebral circulation and autoregulation. Here it is, circle of Willis located at the base of the skull. Here we see anterocerebral artery and middle cerebral artery, which branches as ophthalmic artery, anterochoroidal artery, and internal carotid artery. And posterior communicating artery branch from the middle cerebral artery, which joins posterior cerebral artery. And along with posterior cerebral artery, superior cerebral artery joins and continues as basilar artery, from which pontine arteries arises. Basilar arteries branches are anterior inferior cerebellar artery, and it continues as two vertebral arteries. In 85% of people, anterior inferior cerebellar artery branches from basilar artery, and in 15% it branches from the vertebral artery. And posterior inferior cerebellar artery arises from the vertebral artery, and anterior spinal artery uh, arises from vertebral artery, and it supplies anterior two-thirds of the spinal cord. Venous drainage. There are three sets of veins drain from the brain. There are superficial cortical veins and deep cortical veins, which finally drains into dural venous sinuses. And all these veins ultimately drain into both right and left internal jugular veins. Coming to regulation of cerebral blood flow. Brain's weight is 1350 grams, which is only 2% of the body weight, but it receives blood flow of 12 to 15% of cardiac output, that is approximately 750 ml per minute. And brain consumes 3.5 ml oxygen per 100 gram per minute, which is defined as cerebral metabolic rate of oxygen. Coming to global blood flow, it is 45 to 55 ml per 100 gram per minute. And cortical gray matter receives 75 to 80 ml per 100 gram per minute, and subcortical white matter receives 20 ml per 100 gram per minute. And this is cerebral metabolic rate of oxygen, which is 3 to 3.5 ml per 100 gram per minute. Then normal intracranial pressure in supine position is 8 to 12 millimeter mercury. Coming to chemical regulation of cerebral blood flow, central metabolic rate of oxygen. When there is increased neuronal activity, there is increased local brain metabolism, and there is increased cerebral metabolic rate of oxygen. Increase in cerebral metabolic rate related with proportional changes in cerebral blood flow is known as flow metabolism coupling or neurovascular coupling, and it is a positive feedback mechanism. Increased activity in neuronal space leads to increased metabolites, that is potassium, H plus, lactate, and adenosine, resulting in vasodilatation, and it results in pivotal role in increasing cerebral blood flow. Increasing synaptic activity increase glutamate, which in generation of downstream mediators like increase nitric oxide results in vasodilatation. Other neurotransmitters involved in neurovascular coupling are vasoactive intestinal peptide, substance P, cholecystokinin, somatostatin, and castoin gene-related peptide. Cerebral metabolic rate is influenced by functional status of CNS. Cerebral metabolic rate decrease in sleep and increase during sensory stimulation of nerve. And second is anesthetic drugs. There is complete suppression of EEG, burst suppression. Third one is temperature. For every degree Celsius reduction in temperature, cerebral metabolic rate decreases by 6 to 7%. Here is graphical representation of effect of temperature. From 37 degrees Celsius to 27 and 17, for every degree Celsius, there is decrease in cerebral metabolic rate of oxygen. PaCO2, partial pressure of carbon dioxide in artery. Cerebral blood flow varies directly with PaCO2. For every 1 millimeter mercury change, that is increase or decrease, there is a respective increase or decrease in cerebral blood flow, that is 1 to 2 ml per 100 gram per minute. Changes in cerebral blood flow caused by PaCO2 are dependent on pH alterations in the extracellular fluid of the blood. nitric oxide in particular of neuronal origin is an important, although not exclusive, mediator of carbon dioxide-induced vasodilatation. The vasodilator response to hypercapnia is also mediated in part by prostaglandins. In contrast with respiratory acidosis, systemic metabolic alkalosis acidosis has little immediate effect on cerebral blood flow because the blood-brain barrier excludes H+ from the perivascular space. PaO2, partial pressure of oxygen. Only marked changes in PaO2 affect cerebral blood flow. That is, if PaO2 is decreased less than 50 millimeter mercury, then only we see increased cerebral blood flow. Cerebral vasodilatation in hypoxia is mediated by peripheral and neuraxial chemoreceptors and local humor receptors. That is, hypoxia, that is decreased PaO2 is sensed by the peripheral chemoreceptors, whereas rise in PaCO2 is sensed by the central chemoreceptors, which is sensed by the pH in the CSF by central chemoreceptors. Hypoxia induced opening of ATP dependent potassium channels in vascular smooth muscles results in opening of potassium channels, hyperpolarization, and vasodilatation, resulting in increased cerebral blood flow. Stimulation of rostral ventrolateral medulla by hypoxia, which is oxygen sensor in the brain, increase in cerebral blood flow. There is no change in cerebral metabolic rate of oxygen. Coming to myogenic regulation, autoregulation. The capacity of cerebral circulation to adjust its resistance to maintain cerebral blood flow constant over a wide range of mean arterial pressure is defined as autoregulation. This is between maintaining MAP of 70 to 150 mmHg and somewhere it is 60 to 160 mmHg. The lower limit of autoregulation is widely quoted as MAP of 50 mmHg. Above or below the autoregulation plateau, cerebral blood flow is pressure dependent and varies linearly with cerebral perfusion pressure. Cerebral perfusion pressure is defined as the difference between mean arterial pressure and the intracranial pressure. That is MAP of 60 to 150 mmHg minus 10 mmHg, which is the normal intracranial pressure. Changes in cerebral perfusion pressure lead to direct changes in the tone of vascular smooth muscle. Chronic systemic hypertension shifts the autoregulation curve to the right, such that decrease in cerebral blood flow occurs at MAP of greater than 60 mmHg in chronic systemic hypertensive patients. This is the cerebral perfusion pressure from 50 to 160. Cerebral blood flow is maintained constantly due to autoregulation. Below the 50 mmHg or above 160 mmHg, there is increase or decrease in cerebral blood flow. This is the graph representing effect of PaO2, PaCO2, and MAP in cerebral blood flow. Here PaCO2 with it is linked linearly with the PaCO2 as I told. With one increase in 1 mmHg PaCO2, there is 1 to 2 ml increase in cerebral blood flow. This is PaCO2. Only below 50 mmHg PaO2, there is increased cerebral blood flow, as we see. This is the brown curve. This blue curve is the autoregulation, as I told, MAP from 50 to 160. Effects of blood viscosity. Blood viscosity can increase cerebral blood flow. Hematocrit PCV is the single most important determinant of blood viscosity. And in conditions like anemia, we see increased cerebral blood flow, and polycythemia, decreased blood flow. This is the picture representing MAP by various mechanisms. Metabolic mechanism by PaCO2, as I told, transmural pressure of blood vessel, myogenic tone, neurogenic response in at synaptic level. These mediators, nitric oxide, acetylcholine, serotonin, neuropeptide by acetol, resulting in vasodilatation and endothelial smooth muscle interaction. Endothelial nitric oxide synthesis resulting in vasodilatation, resulting in increased cerebral blood flow. Effects of anesthetics on cerebral blood flow and cerebral metabolic rate of oxygen. Coming to intravenous anesthetic drugs, the action of most IV anesthetics leads to parallel reduction in cerebral metabolic rate and cerebral blood flow. There are some exceptions like ketamine, which increases both cerebral metabolic rate and cerebral blood flow. It is also dependent on action of IV agents on vasoconstriction, dilatation, and alteration of autoregulated function that we are going to see. Coming to barbiturates, example thiopenton phenobarbital, a dose-dependent reduction in both cerebral blood flow and cerebral metabolic rate, and it is reduced by 30%. When large doses of thiopenton causes complete EEG suppression, cerebral blood flow and cerebral metabolic rate are reduced by about 50%. Further increase of dose of barbiturate have no effect on cerebral metabolic rate. In major neurosurgeries, we induce barbiturate coma, that is temporary coma, that is deep state of unconsciousness brought on by controlled dose of barbiturate drug. Common IV agent propofol. Here we see substantial reduction in both cerebral blood flow and cerebral metabolic rate of oxygen. As blood flow is decreased, intracranial pressure is automatically decreased. It reduces renal blood flow by 53 to 79% in comparison with awake state. Both carbon dioxide responsiveness, that is PaCO2 response to cerebral blood flow, and autoregulation are preserved while using propofol. Another IV induction drug, etomidate. It's a potent cerebral vasoconstrictor. It decreases cerebral blood flow and CMR like barbiturates. And in barbiturates, mostly we used in neurosurgeries as it decreases both the cerebral metabolic rate of oxygen, thereby reducing cerebral blood flow, and intracranial pressure is reduced. Similarly, like that only etomidate also. Progressive suppression of EEG is seen. Etomidate is effective in reduced ICP without causing reduction in cerebral perfusion pressure in patients with intracranial tumors and patients with head injury. And similar to propofol also, reactive to carbon dioxide is preserved. Coming to narcotics, little effect on cerebral blood flow and metabolic rate in the normal unstimulated nervous system. Morphine, it has no effect on global cerebral blood flow and 41% decrease in cerebral metabolic rate of oxygen. Due to histamine release, there is local cerebral vasodilator effect, increasing cerebral blood volume and variable cerebral blood flow effect depending on systemic blood pressure response. Fentanyl, we see global reduction in cerebral blood flow and cerebral metabolic rate. And it is similar to morphine, cause larger reductions when administered during arousal. Alfentanil, it does not significantly impact the cerebral circulation, provided that alphanil induced reduction in MAP is prevented. Remifentanil, which is commonly used in daycare surgeries with larger doses or with the concomitant administration of anesthetic drugs, cerebral blood flow is either unaltered or modestly reduced. These are the effects of narcotics. It has little effect on cerebral blood flow and metabolic rate. Ketamine is the only exceptional IV injection drug which increase both cerebral blood flow and cerebral metabolic rate. That's why it is most contraindicated in neurosurgeries, as it increases cerebral intracranial pressure. During PET studies in humans, it has demonstrated that subanesthetic doses of ketamine, that's 0.2 to 0.3 milligram per kg, increase global cerebral metabolic rate by 20%. There are two enantiomers, there are S and R enantiomers. S enantiomer of ketamine increase cerebral metabolic rate, which substantially increase cerebral blood flow. Whereas R enantiomer tends to decrease cerebral metabolic rate, particularly in temporomedial cortex and cerebellum. These are accompanied by corresponding changes in CBS. Carbon dioxide responsiveness is preserved, and raised effects of ICP by ketamine is blunted by the other anesthetic drugs like benzodiazepines or propofol. And it is, as I told, best avoided as sole anesthetic agent with impaired intracranial complex like intracranial tumor surgeries, raised ICP surgeries. And it can elicit seizures in patients with epilepsy. Anesthetic adjuvants like intravenous lignocaine. It decreases cerebral metabolic rate of oxygen, thereby cerebral blood flow and intracranial pressure. Its advantage is that it decreases cerebral blood flow without causing other significant hemodynamic effects like hypotension or all. It also has neuroprotective effects like thiopental. Lidocaine infusions are used as supplement to general anesthesia to reduce emergency delirium and the requirement for opioids. It has membrane stabilizing property, thereby decreases cerebral metabolic rate of oxygen. It can be used as adjunct in prevention or treatment of acute increases in intracranial pressure. Vasopressors. With normal autoregulation and an intact blood-brain barrier, vasopressors increase cerebral blood flow only when mean arterial pressure is below 50 to 60 mmHg or above 150 to 160 mmHg. That is map higher or lower levels. In the absence of autoregulation, vasopressors increase cerebral blood flow by their effect on cerebral perfusion pressure. Beta adrenergic agents seem to have greater effect on the brain when blood-brain barrier is disrupted. Central beta-1 receptor stimulation increases cerebral metabolic rate and blood flow. Beta blockers generally have no direct effect on cerebral metabolic rate or cerebral blood flow, whereas alpha-2 adrenergic agonists like clonidine and temolone produce cerebral vasoconstriction. Excessive elevations in blood pressure with any agent can disrupt blood-brain barrier. Vasodilators. In the absence of hypotension, most vasodilators like hydralazine, nitroprusside induce cerebral vasodilatation and increase cerebral blood flow in dose-related fashion. When these agents decrease BP, cerebral blood flow is usually maintained and may even increase. The resultant increase in cerebral blood volume can significantly elevate ICP in patients with decreased intracranial confluence. Neurovascular blocking agents has direct action on the brain but have important secondary effects. Hypertension and histamine-mediated cerebral vasodilatation, like morphine, increase cerebral blood flow, thereby increase intracranial pressure, whereas systemic hypotension from histamine release or ganglionic blockade lowers cerebral perfusion pressure. Choline can increase intracranial pressure as a result of cerebral activation associated with enhanced muscle spindle activity, but the increase is generally minimal and clinically unimportant. An adequate dose of propofol is given and hyperventilation initiated at induction. Coming to inhalational agents, volatile anesthetics, it suppresses cerebral metabolism in a dose-related manner. As the dose MAC increases, there is increased cerebral blood flow, thereby increasing intracranial pressure with MAC. It possesses intrinsic cerebral vasodilator activity as a result of direct effects on vascular smooth muscle. The net effect is there is a balance between reduction cerebral blood flow by cerebral metabolic rate suppression and augmentation of cerebral blood flow by direct cerebral vasodilatation. At 0.5 MAC, cerebral metabolic rate suppression induced reduction in cerebral blood flow predominates. Thereby, net effect is cerebral blood flow decreases compared to AVEX state. At 1 MAC, cerebral blood flow remains unchanged because there is balance between cerebral metabolic rate suppression and vasodilator effect. So there is no increased blood flow or decreased blood flow. There is stable at 1 MAC. Beyond 1 MAC, the vasodilator activity predominates, thereby increasing cerebral blood flow. This is the graph representing the mean arterial pressure and the cerebral blood flow. Orange one increases represents the greater than 1 MAC. This one at 1 MAC. This is less than 1 MAC. That is 0.5 MAC. As I told you, at 0.5 MAC, cerebral metabolic rate suppression predominates. So there is net effect is cerebral blood flow decreases. At 1 MAC, there is balance between cerebral metabolic rate suppression and vasodilator effect of volatile anesthetics. So net effect is unchanged. Beyond 1 MAC, cerebral metabolic rate reduced, but vasodilator effect of volatile anesthetics predominates. So there is increased blood flow. Coming to nitrous oxide agent, is similar to inhalational agents. When combined with IV agents, nitrous oxide has minimal effect on cerebral blood flow, cerebral metabolic rate, and ICP. Adding this agent to a volatile anesthetics increases cerebral blood flow. When given alone, nitrous oxide causes mild cerebral vasodilatation and can potentially increase intracranial pressure. These are the effects of various inhalational agents on cerebral metabolic rate, cerebral blood flow and intracranial pressure. Only in exceptional agent is ketamine. Here we see increased cerebral metabolic rate and increased cerebral blood flow, thereby raising the intracranial pressure. And volatile agents also increase intracranial pressure as they cause cerebral vasodilatation, thereby increasing cerebral blood flow. The schematic representation of cerebral blood flow. Left side ones cause decreased cerebral blood flow and right ones cause increased cerebral blood flow. Hypocapnia, PSO2 decrease cerebral blood flow. Benzodiazepines, barbiturates, propofol agents decrease cerebral blood flow. These are the agents right side cause increased cerebral blood flow. Example, ketamine, volatile agent, nitric oxide, inhalational agents. Thank you.
Topic is open for discussion. The topic is open for discussion. Any questions?
Why so silent? అందరూ బాగా అర్థమైపోయింది క్లాస్ అందరికి. Omkar and Chaitanya, please ask any questions related to DNB students, like that they can answer.
Good morning, sir. Actually, నేను చాలా లేట్ గా జాయిన్ అయ్యాను and I hope he covered everything.
Okay, nice.
Ravi is not there, huh?
Sir, can I ask one question?
Yes, sir.
Sure.
What is flow metabolism coupling?
When there is increased cerebral metabolic rate of oxygen, there is corresponding increased cerebral blood flow due to increased requirement of oxygen. That is called neurovascular coupling or cerebral flow metabolic coupling, sir.
Dissociation of flow metabolism coupling occurs with what? Flow metabolism coupling means when flow increases, metabolism also increases. When
Metabolism.
flow decreases, metabolism also decreases.
Yes,
This is
sir.
a protective phenomenon of cerebral circulation.
Yes, sir. When there is dissociation of autoregulation, when autoregulation is disrupted, this coupling is disrupted.
All intravenous anesthetics, they maintain the coupling.
Yes, sir.
All inhalation anesthetics more than 1.5 MAC, they dissociate the flow metabolism coupling. So if at all you want to use an inhalation anesthetic, you should not increase above 1.5 MAC and also initially hyperventilate and give inhalation anesthetics.
Yes, sir.
What is luxury perfusion?
Luxury perfusion is though decrease decreased requirement of oxygen, that is decreased cerebral metabolic rate of oxygen, we see increased perfusion in that area. That is a luxury perfusion, sir. Though there is no normal or decreased cerebral metabolic rate of oxygen, we see more cerebral blood flow to that area.
Which is the single most important point for cerebral circulation among PaO2, PaCO2, MAP, and temperature. Of these four, which is most important?
Temperature, sir.
No, MAP. MAP is most important. You told also anatomy of the cerebral circulation, only factors.
Yes, sir.
Huh? I also joined late. I did not hear.
Starting lo chepparu sir, anatomy kuda chepparu.
What is A1 segment?
Yeah.
A1 segment is that part of the anterior cerebral artery after giving anterior communicating branch.
Okay, sir.
Sorry, A2 segment. A1 is before, proximal to the communicating branch.
Okay, sir.
These are important because of when you are going to clip the cerebral aneurysms, they will report in MRI or angiography that the aneurysm is in A1 segment, A2 segment, like that.
Okay, sir.
Okay, thank you.
Omkar, any questions?
Okay, we shall wind up, Shekhar.
Okay, nice presentation.
Nice class, Kranti. Thank you.
Thank you. Hello, sir. సార్ నేను టెన్షన్లో ఉన్నాను సార్ గుర్తు తెచ్చుకోండి సెమినార్ హాల్లో ఉన్నాను సార్ సరే సార్ వస్తాను